Good morning, everyone. We'll call the first speaker without delay. So, Dr. Ejaz Ahmed, if he's here. Okay. Dr. Ejaz, is he here? Okay. So, he'll be talking about the radiological evaluation of locally advanced carcinoma gallbladder.
Good morning, everyone, and good morning, Chairperson, respected Chairperson. And today, to start of the day today, it will be more of radiology presentation from my end, which will be dealt in terms of locally advanced gallbladder cancer, a review of the criteria and the role of imaging in terms of locally advanced gallbladder cancer. I am Dr. Ejaz Ahmed Bari, and I am the head and consultant at Department of Radiology, Amri Mukundapur. So, without delay, let's start. Majority of the patients with gallbladder cancers are not considered candidates for surgery because of the locally advanced disease or METs. However, with the accumulating evidence regarding the role of neoadjuvant chemotherapy, NACT, we need to actually identify a subset of patients with LHGBC who will benefit maximally with NACT and will be successfully downstage to receive curative surgery, RO. Here, imaging plays a critical role in the evaluation of patients with GBC, as it helps to stratify patients into whether they are resectable or unresectable. Apart from that, imaging also has the potential to identify patients with locally advanced GBC and hence facilitates neoadjuvant chemotherapy and improve their outcomes. Like colon cancer, GBC also progresses from dysplasia to carcinoma in situ and also to invasive carcinoma over time. And majority of the tumors of gallbladder starts from the fundus, and the most common is adenoCA. Less than 10% of the patients of GBC present with disease limited to the gallbladder. GBC, as we all know, spreads by direct, by lymphatic routes, by the vascular, neural and the ductal routes. So what is major out here is in terms of the end staging is the ductal routes, which is notably the cystic, the pericholedochal groups and subsequently the pancreatic or duodenal groups, as well as the periportal groups. These groups actually comprise the loco-regional nodes for GBC, and this is what it is dealt out here in terms of imaging for locally advanced GB carcinoma. Involvement of the celiac, the mesenteric and the retroperitoneal nodes form the metastatic nodes. Small depiction of the spread of the nodes in terms of metastatic nodes for GBC. The main area of spread, usually the gallbladder, the sentinel nodes are supposed to be the cystic nodes out here. And then via the pericholedochal lymphatics, which is within the hepatoduodenal ligament, as we can see here, the blue thing is the hepatoduodenal ligament. We have a posterior drainage, the major part, and the anterior drainage as well. The posterior drainage among them, the most common is the cholecysto-retropancreatic pathway. This is the main pathway which is depicted in orange. As you can see, this orange, as it comes down, this is the first. So this is the main pathway of spread of the nodal disease. The other pathways which are second and third which comes is the cholecystoceliac pathway, which is represented in terms of blue. This is the second one, and the third is the cholecysto-mesenteric pathway, which is depicted by pink as it comes down to the mesenteric area. So these are the three major routes of spread in terms of metastasis, in terms of lymph nodes for GBC. Now we have the anterior drainage which follows the hepatic and the celiac artery. Also we have the posterior drainage which we were talking about, the cholecysto-retropancreatic pathway. So these two final pathways goes and joins the cisterna chyli, two into the thoracic duct and into the supraclavicular node. Now liver per se, the segments 4 and segment 5 and the ducts, hepatic ducts and the stomach and duodenum, they are usually involved by direct invasion by the GBC. As GB is very proximal to various other organs and there is absence of muscularis mucosa, and because of extensive lymphatic supply to GB, these were the probable reasons for such extensive spread. Intraperitoneal metastasis seen in 20 to 25%, while intraductal, per se intraductal and intravenous spreads are less common. And hematogenous spreads definitely occurs, but at a later stage. So what exactly is the role of imaging in staging of subsequent planning of LAGBC? LAGB, locally advanced gallbladder cancer. Ultrasound remains the initial investigation of choice in terms of imaging. Ultrasound is sensitive for evaluation of the gallbladder mural thickening or mass and local extension into the liver. So it's very sensitive in terms of mural thickening. We all can appreciate this thickening very nicely. However, ultrasound in terms of staging is limited and it is less reliable for detection of lymph nodes and peritoneal mets. Here are two images that we had of ultrasound where we could find asymmetrical wall thickening involving the gallbladder. This is the gallbladder which entrapped a bit of calculi out here, which is more or less diffuse. Here we have a mural asymmetrical wall thickening within the gallbladder, taking up color as well. So these two cases were of gallbladder cancer in terms of ultrasound. Now coming to CT and MRI. CT and MRI are the cornerstone for imaging in terms of staging of gallbladder cancer. Which of those I'll be coming to my later slides. GBC usually appears as a mass which completely occupies or replaces the gallbladder lumen. As you can see here, this is the liver, this is a CT scan, axial cuts, these are the kidneys. So the GB out here has replaced almost completely, the mass has replaced the gallbladder, which is majority of the presentation tends to happen at 40 to 65%. Apart, we can get asymmetrical wall thickening of GB. There are another CT images that we can see here. CT scan and MRI, as we know, go forward, contrast enhanced CT, 84% sensitive for T stage and 85% for hepatic involvement and vascular involvement. Here we have two images of MRI. Here the GB is replaced by a mass with entrapped calculi, and again we have a MR out here which shows asymmetrical wall thickening. A lot of studies have come up which modality to use among the two. MRI with MRCP is 100% sensitive for bile duct invasion and vascular invasion, but less sensitive 67% for hepatic invasion and 56% for node metastasis. But Singh et al. Dynamic contrast MRI and MRCP, they found it to be very sensitive but less sensitive for duodenal invasion and omental mets. So both CT and MRI have got variable sensitivity, but both are very unreliable in terms of lymph nodes which are less than 10 millimeters. So final recommendation, MRI and MRCP for T staging and contrast enhanced CT scan for distant mets and vascular involvement. PET CT definitely is a very valuable tool in terms of to know about the mets and planning for NACT. We had the Shukla and team who compared PET CT and CT with positive predictive value of close 87 and 87 and 100% and 87 and 91% in terms of PET CT and CT. And he found that 46% of the patients were up stage to stage 4 when a PET CT was done. Apart, as PET CT has got a high false positive rate, it is always advisable to have histopathology for the same. So role of imaging, RO resection is the only curative for GBC. NACT helps in downstaging the disease and gets RO resection. So it's important to identify those patients. There is no randomized, as there is no randomized clinical trials, many authors have institution-based protocols to do that. So before going on to those trials, here's just small cartoon which represents what are the criteria for there. So the T3 and T4 tumors greater than 2 centimeter involving the liver, nodal disease at the hepatic artery region, retropancreatic region, or the hepatoduodenal ligament, and vessels being involved less than 180 degree, hepatic artery and the portal vein, and involvement of the duodenum or the hepatic flexure. So this is a table which summarizes, but the important ones like Siroy team who had achieved 46% RO resection with using only CE, CT and PET CT. We had engineer and at all who had a prospective study and could achieve 50% of RO resection with using CCT, PET CT and further NACT. Chaudhary et al. Had 40% RO resection rate after NACT. So if we go ahead with individually, the Sirohi guys, they used CCT and PET-CT only, and further were given NACT. So they showed 46% of RO resection, and their criteria was gallbladder mass more than 2 centimeter involving the liver and the mass adherent to duodenum. Chaudhary and team proposed a clinico-radiology criteria called the TMH criteria based on the high-risk features for disease recurrence to identify the need for systemic chemotherapy. They used both PET-CT and CCT as well. So using this criteria that they used as the T3, T4 tumors and N1 stations, vessels getting less than 180 degree of involvement. PET-CT, CT and MRI was done by Bernbohr, and T3, T4 stages and N2 involvement were also involved, and they had a very good post-operative outcome of 86%. Engineer et al., they had a T3 and T4 lesions as well, which underwent a NACT, and they could achieve 56% RO resection. Here are some images that I will be going through fast. So here we have a lesion which is completely involving the liver as well, and also it was causing stomach outlet obstruction by the lesion. Here it is involving the bile duct, which is seen on a cholangiogram at the side. This we have a periportal node and a para-aortic nodes as well for this patient. Here we have the lesion getting involving the hepatic artery, and here we have a lesion which is involving the portal vein. This is a PET-CT and a fusion of the CT out here. These are the PET-CT images, these are CT images, and this is a whole coronal body imaging. What we see here is a high uptake of FDG, which corresponds to the high uptake of FDG, which corresponds to on CT is a mass out here in the gallbladder fossa region, and which also has got a portocaval node out here. Apart, what we see here is the involvement of the stomach by this lesion. Now, imaging after NACT, a multimodality approach comprising contrast enhanced CT or MRI and ultrasound is required for thorough assessment. There is no specific response assessment criteria for GBC following NACT. Application of conventional criteria like RECIST and mRECIST is challenging. There is no defined protocols for interval imaging of patients undergoing NACT, as well as no criteria, clinical or radiological, to determine treatment endpoints and differentiate responders from non-responders. There is no guidelines on the recommended imaging. 1 minute I will take. There is no guidelines on the recommended imaging after NACT. Published studies have employed CCT, MRI and or PET-CT for staging post-NACT response. Last image that I want to put across is these were the images pre-NACT and this is post-NACT. We have a mural thickening involvement of the liver. As we go further, these are the pre-NACT, post-NACT. What we see here is, though the gallbladder lesion hasn't been downstaged much, but the involvement of the liver has definitely been downstage. Also, we have the omental thickening here happening, which is getting downstage in F as well. So, downstage in terms of liver as well as omental involvement. So, conclusion, GBC very dismal prognosis without curative surgery. In this context, radiology evaluation plays a defining role in staging and selecting patients for LAGBC for NACT and further RO resection. So, we as a radiologist, we must be aware of the features of locally advanced gallbladder cancer when reporting imaging, so that we can guide further management, NACT and curative surgery. Thank you so much. Thank you all of you.
Thank you, Dr. Ejaz. While we wait questions from the floor, would you consider endosonography also as part of radiological evaluation, especially since your nodes were not so good in many of those, apart from say PET?
Endosonographies are usually, the radiologist doesn't do majority of the time. It is the gastroenterologist who does it. For us, it is more of the cross-sectional imaging that we try to put across in terms of GBC.
So from the pre-surgical viewpoint, those para-aortic nodes and all those, what would you consider as the best modality for those?
CT scan, sir.
Anybody?
Now, you colleagues, ultrasonologists are so expert, they pick up early lesion. Say clinically it is T2, a small mass in the intraluminal part of gallbladder. Do you think PET-CT should be done in all such cases, or what is the indication in early CAGB of PET-CT?
I agree. Now, what has happened, sir, this is a big topic that has come up, but in terms of, first of all, when we are doing an ultrasound, the first thing that we come out to know is whether, the thickening is which way. If we suspect, yeah, it looks more towards a neoplastic lesion, definitely, the size of the lesion will be a matter and will be the deciding factor in terms of PET CT. If it is less than 10 millimeters, PET CT again will be, dicey. So for me, I suppose we start with ultrasound and we go ahead with a PET CT to look out for anything apart from, the gallbladder thickening that is happening. Now, if it is equivocal, we go ahead and do a PET CT. Definitely a PET CT will be high on the list for us after CECT.
In our study, we have shown that even in a smaller lesion, which was totally upfront resectable, around 12% will find metastatic disease in that goods. And locally advanced, the finding of metastasis up to 35 or 36%. So even in a resectable, upfront resectable, it is better to do a PET scan.
What we have shown, the paper which is quoted are my paper only. So I think still there is no consensus, no guidelines which recommend PET CT scan in gallbladder cancer. For early gallbladder cancer, there is definitely no role even for staging and post-op. Only two places where PET CT scan has shown benefit is in restaging for incidental gallbladder cancer, once they present to you after 3 to 4 weeks after the index surgery, and in locally advanced gallbladder cancer, where we have shown that almost 45% upstaging occurs.
Yes.
So these are the two places where PET scan has shown benefit. Barring that, no guidelines recommend PET scan as of now.
Until we do prospective studies on this in a otherwise bad,
Now the UK guidelines include now a PET scan as all, and they have quoted, it is a standard recommendation, and they have quoted our paper for that.
So they were, majority of the studies were retrospective. One was prospective study by the engineer team. The engineer guys and team, they had a prospective study, others were retrospective studies. And very rightly said, as we had shown that, PET CT upstaged majority of them, 46% of the cases to stage 4 after doing a PET CT. So definitely PET CT plays a big role out here as well.
Thank you. I think one of the problems is internationally that they combine all the other biliary cancers. So PET doesn't have such a great role in cholangio. So I think that's one of the reasons for the discrepancies. So we do need good prospective studies from here.
And also it has been recommended, because PET CT has got a high false positive rate, we should have a histopathology confirmation before going ahead with a...
That's the other problem. We never normally get a diagnosis before. Yeah. Thank you, Dr. Ejaz. I think there are no further questions.